Good evening, good morning, or good day, depending on where you are. Welcome to the IFSO APC webinar for January 2024. Looking ahead, we have a big year. For us in the IFSO APC, hosting global conference in my hometown of Melbourne is very exciting, and there's a lot else on the radar. So we thought we would start this webinar by looking forward at the year or years ahead, and some of the trends, issues, and controversies that might be coming our way. Before we do so, though, I'd like to remind you that this webinar will be recorded and available afterwards on the IFSO YouTube channel and also on the IFSO Virtual Academy. Throughout this webinar, you're very welcome and encouraged to ask any questions that we will attempt to address to our panelists after their presentations and discuss them with some of APC and the world's experts in these areas. And from there, we'll move on. My name is Alex Craven. I am a bariatric surgeon in Melbourne, Australia. And my next guest needs no introduction, but I'm going to do it anyway. Associate Professor Ahmed Ali is the head of upper gastrointestinal and bariatric surgery at the Austin Hospital in Melbourne. He is a very experienced, knowledgeable and well-regarded bariatric surgeon here in Australia and around the world, and a key contributor to IFSO APC and globally for many years now. He has been involved in a number of key initiatives driving improvements in bariatric surgery in our country and beyond. And I introduce him now as the President-elect of the IFSO APC, and also for this year, our Congress President for the IFSO Global Conference, as I said, coming to our hometown of Melbourne. Ahmed, welcome. Thanks for getting involved.
Thanks, Alex. That's a very kind introduction. I tend to think of myself as just one of the members of the IFSO APC family. So welcome everyone to this webinar. Alex has done a great job putting it together, and you've got a very exciting program. I'm a little bit of an imposter, really. I'm just here to introduce you to the Congress coming up in September, give you a little bit of a flavour about that, and encourage you all to come along, make your plans now, book a holiday, come down to Melbourne, come down and see us. And participate in this great Congress. So I've got a few slides that I'll share in that regard, and hopefully won't hold you all up too long. So as I said, welcome to Melbourne for the 27th IFSO World Congress in 2024. It is going to be held in the early weeks of September, which in Melbourne is springtime. It's usually lovely weather. The chill of winter is just disappearing. It's starting to get a little bit warmer. The flowers are out, the grass is being cut, and everyone's in a really good mood. So it's a great time to be in Melbourne. The exhibition centre is right in the heart of Melbourne. So you can get here, you land at the airport, 25 minutes later, you'll be in a hotel room right next to the convention centre and only a few minutes away from the action in Melbourne. We've formed a local Congress committee of names I'm sure that you recognise as you go down that list. And I just note, just to make note of the late Ken Loy, who was part of this initiative when we started 2 years ago, and unfortunately has passed away, much to our sadness. So just a little note of thanks and memory of Ken. That committee's worked hard to work towards bringing you a uniquely inclusive program at this meeting. We're hoping that we will deliver to you a wonderful experience. In fact, we're confident that we'll deliver that to you. And we're really conscious of this conference being in the APC region and focusing on our APC colleagues, that is you. What's special about this Congress for you in APC? What is it that it can offer to you outside of your normal everyday activity? And I think this is really the big one, isn't it? Most of the IFSO Congresses are held in faraway places as far as we're concerned. They're in Europe or the Americas, often on the other side of the world. And that makes it hard for us to get to them. And many of our colleagues and brothers and sisters in the APC region really find it very difficult to attend an IFSO World Congress. In fact, many never will because of the tyranny of distance and expense and cost. But this is your conference. This conference, yes, it's in Melbourne, but this is in the Asia Pacific region. Much easier to travel to, the proximities there. We are all neighbours. And so it is your meeting. It's easier to travel. It's more affordable because of that reason. We're making sure that we're securing good budget accommodation as well, because we know there are a lot of young surgeons that are emerging in the Asia Pacific region for whom perhaps expense is very important. And I'll make a note that the currency exchange with the Australian dollar is much more favourable than that of the US dollar or the euro. And being in your area, there's less jet lag you have to worry about when you get home and trying to catch up on that sleep. The last time it was in the APC region was 2006. It was in Sydney. So, almost, almost more than nearly 2 decades. And I think for many in the APC region, this might be really one of the few opportunities, perhaps the last opportunity to attend an IFSO World Congress. This is really a great opportunity for everyone in the APC region. But there are other reasons why this is important and what it can offer, and that is that the APC region is really, I think, an emerging giant of metabolic surgery. The APC region has 4 billion people in population, which is 60% of the world's population, and surgery is increasing rapidly. Bariatric metabolic surgery has increased over 360% in the last 10 years. It is exploding in this region. And we can see that particularly in the last year, this is the 8th World Registry report from IFSO, looking at the numbers from 2022. And we would never have seen this before. But I'll just point out that China are now 4th in the list of countries that are contributing numbers to the registry. If you go back even 5 years, they were down near the bottom. Surgery, metabolic surgery is advancing so quickly in our region that it's time to showcase that in the APC. So come, share your research, share your experience, share your learning. The abstracts are open. We're going to take lots of free papers. We need to hear from you. We need to hear from our APC colleagues. Don't sit there in isolation. You've got stuff to share and stuff to bring to us, things that we can all learn from and we can show the world. And this is a great opportunity to do that. On the other side of it, though, our experience in the APC region is still relatively young. Yes, in Australia, we've been doing surgery for a long time, but many of our neighbours haven't. So that's emerging. And again, by comparison, when we look at revisional surgery, China is much further down on that list. So 4th overall for primary surgery, but in terms of revisional experience, much less. So there is a youth of experience here. And for that reason, we're going to focus on young people as well in the APC region, with scholarships and travelling fellowships being available. Keep an eye on the website for the details about that. We are specifically going to run an early career fundamentals course in our postgraduate courses on the Tuesday that occur before the conference. This is going to be focused on young graduates, young surgeons, trainees, fellows, people that are emerging in their experience of bariatric surgery. We're going to really focus on the fundamentals, getting them up and away and feeling confident in their practice, with sessions aimed at improving core knowledge through the conference, but also forecasting what the future looks like, because these are the young surgeons that will inherit the future. The theme of the conference is integration, and that can be across all sorts of areas. Yes, we can talk about multidisciplinary care and integration of multimodal therapy. We can talk about the use of teams, effective use of teams in theatres and in clinical scenarios and even in research. We can talk about integration of our basic science, our metabolic care, the future, technology, advances in surgical theory. All of these things will be explored at this conference. So I really urge you to promote this meeting amongst your colleagues, especially your younger trainees and fellows. They may not have an opportunity to get to an IFSO World Congress that is so close for many, many years. And bring your teams, because that theme of integration means there's plenty for them to share and plenty of things for them to learn at this conference. We want to make this conference amazing, make it easy for people and wonderful. And Australia really helps us with that. Melbourne is perfect for our APC colleagues because Melbourne is a very multicultural city. We've got a lot of Asia Pacific representation. In fact, in many ways, you can turn up in Melbourne and feel really quite at home. So it's not daunting at all for people that have never travelled. They'll feel comfortable and welcomed immediately. The conference centre is right along the banks of the Yarra River, which runs right through the city. And in fact, all you need to do is cross that bridge over the river and you'll be right in the heart of the city. Very easy access, easy to explore the great food and coffee and the cafes and the laneways of Melbourne, as well as a host of other entertainment. So you'll never be bored, even if you just tour around in Melbourne. But of course, you can get outside of Melbourne as well, and we'll organise day trips and social program to visit some of the amazing sites. Australia is very well known for its wildlife and its amazing scenery and exploration that you can undertake. And everyone wants to see a koala. You can do that within half an hour of Melbourne. You can even cuddle a koala, and if you're really brave, you can kiss a koala as well. So if there's nothing else, come kiss a koala. Play with a platypus. Gallivant with a galah, perhaps, wander around with a wombat. Maybe don't hug the echidna, they're a little bit spiky, but everyone wants to jump with a kangaroo. So these are all things that you'll only experience if you come down to Melbourne, and what better reason to do it than to come to the World Congress. Maybe don't get too close to these fellas though, they leave that to the experts. But come and experience Australia. So come for the Congress, yes, but give yourself a little bit of time to explore. This is a once in a lifetime opportunity. We will be partnering with a travel agent so we can create customised travel packages for you throughout the country, or even if you just want in Melbourne. There's just so much to see, you won't be disappointed. Abstracts are already open. Registration will open around the end of January. And remember, the early bird closure is in June, so get in and register early. Start planning.
Australia. Whoever came up with this place deserves a real pat on the back. I mean, think about it. There are birds who can laugh, mammals who can sing, waterfalls that can fall both ways, and 126 different shops that all reckon they sell the world's best pie. There are walls that can tell stories, cities that start where the waves end, and there's a lot of nothing, which is actually really something. You've got rivers that can wash your worries away, bush that knows how to bounce back. I heard about places where you can fly, kayak or wade to lunch and get served a delicious beverage by a guy called Jeff. I mean, I don't know if that's his actual name, but gee, that sounds like a pretty incredible day. This is a place that took a look at the rulebook and said, nah, here's a platypus. You know the most incredible thing of all? A holiday here this year is exactly what this place and all of us needs. So get out there. For Australia.
So welcome to IFSO 2024 in Melbourne. We're really hoping to see you there. Thanks very much.
Thanks very much, Ahmed. Two things that spoke to me when you were talking there, I think as younger fellows, I can still remember my first IFSO World Congress when I was a first year general surgical fellow. And I think it was a seminal moment in my training, just to get that perspective and broader understanding. And I think, yes, we're connected technologically in so many ways, but it's not the same as being there in person and being in that community. And you use the word family, and I think that's a good analogy. So yeah, it's gonna be fun.
Definitely. This will be a great conference, and we really want all of our Asia Pacific brothers and sisters to come down because, like I said, it doesn't come down to this region very often. Last time was 2006. This is a great opportunity. Let's not miss out. Let's show the world what we can do.
Yeah, and it's important. I think we work together as things grow across the region. As you'd mentioned, this is where the action is. Obesity rates are climbing in our corner of the world very quickly, and we need to be ready to respond.
Yeah, and I have no doubt that in 10 years, the development that's going to happen in bariatric and metabolic surgery coming out of the Asia Pacific region actually will end up turning the world on its head. This is going to be the region that leads the world in bariatric and metabolic surgery.
Yeah, I couldn't agree more. Anyway, will you hang around and talk, join our panel later on? Because I think there's more for us to discuss. But we will move on to our next speaker. Again, someone I probably don't need to spend a long time introducing because he is well known to us all. Asim Shabir is the current president of the IFSO APC chapter, the head of the Department of Surgery at the National University of Singapore, and a senior consultant at the National University Hospital Singapore. He's an accomplished surgeon, particularly in the area of bariatrics, and we're going to hear from him on video first, but then also in person following that. So we'll hear his presentation now, please, Stephanie.
Hello, good evening. Thank you very much and for the honor for presenting at this forum. I'm Asim Shabir. I'm currently the president of IFSO APC. I have no conflict of interest for this talk, and I have been tasked to speak on how and why lowering of BMI thresholds and the move from BMI to clinical indications matter in APC. So let's address the first topic. The NHI guidelines, basically, we all are well aware of them. In 2013, they were actually reviewed by a committee and they found insufficient evidence because a group of meta-analysis, a group of randomized control trials were excluded. So BMI 35 and below were not indications for metabolic bariatric surgery. Fast forward 2016, you can see that the DSS came up with guidelines where BMI below 35 and even down to 27.5 to Asians were included and published by Cummings in 2016 in Diabetes Care. And it basically showed that surgery or bariatric metabolic surgery was equally effective when compared to those above 35 BMI. If we look at the Asian landscape, and you can see in the bluish colors here, that basically Asia has a low incidence of what we call obesity based on BMI, but we have a heavy burden of other metabolic diseases. If you look at those in Asia above 30 kilograms, we have a plenty of population, a large cohort to treat. And not only that there are patients with obesity, but they do have significant diseases when they are counted at 30 kilograms per meter square and above. And so there's a significant burden of chronic comorbid diseases, including metabolic syndrome, that need to be treated. And thus, because of this, few next slides that I will show, I would state that the BMI thresholds for patients in the Asian continent should be reduced. The YY paradox, where you can see two individuals of similar BMI, but the fattiness or the visceral abdominal fat is much more in the Asian gentleman with 21.2, and thus resulting in comorbid illnesses. And it is clearly known from data that ethnic specific cutoffs for BMI are definitely lower for comorbidities and obesity for Asians compared to their counterparts, Caucasian counterparts. Moreover, the disease and comorbids that arise in Asians arise at a much younger age as compared to their Caucasian counterparts, and then they are poorly controlled. That's meaning that we have BMIs that are lower with higher burden of chronic diseases that are poorly controlled, resulting in complications of these comorbidities, which is a huge health burden in our societies. These are graphs basically showing that young onset patients with diabetes have higher morbidity and mortality compared to those who have delayed onset or maturity onset diabetes. So the first Asian guidelines were seen in 2005, and you can see Asia started already thinking about metabolic surgery more than bariatric surgery at that point in time. IFSO has currently, with ASMBS, updated its guidelines and including metabolic surgery above 35 as an indication for surgery, and those between 30 to 35 considered for bariatric metabolic surgery, and the Asian thresholds are 2.5 kilograms per meter square lesser. These are current prevailing indications for bariatric and metabolic surgery in Asia. Is there data to back that? I don't have enough time, but there is this systematic review done from China, and you can see those below 30 kilograms per meter square, even at 1 year, surgery seems to be having profound effects on BMI, and at 2 years, HbA1c much more better than those who were on medical therapy or before medical therapy. Now let's go to the second topic. A move from BMI to clinical indication matters in APC. Certainly it matters because in 2005, we were already talking about metabolic surgery and not so much bariatric surgery, even based on that. We know that BMI is an epidemiological tool and a research tool, and is associated with increase in mortality depending upon which mortality you look. However, BMI does not help us measure body fattiness. And if it doesn't do that, then we can't very effectively identify and treat patients with metabolic disease. So the other models that have come up are complication-centric models that focus on risk assessment, staging, and stage-specific interventions, of which one strategy is weight loss treatment, but not the only strategy, which is in BMI-centric model, where primary treatment goal is weight loss. In the complication-centric model, the goal is reduction of risk for many comorbidities associated with obesity. When we look at this model, it allows for a holistic approach. And if you look at the look ahead trial, some weight loss, even 5 to 10%, actually produced significant improvement, clinically relevant improvement in cardiovascular disease risk factors in patients with obesity. And at 1 year, the greater the increment, the merrier and the better outcomes we saw. So in order for this to do, we need a disease staging system, a primary factor that guides treatment planning that will be able to evaluate the presence and severity of complication and not merely BMI per se. And this was done by the Edmonton Obesity Staging Group, which was led by Dr. Sharma in 2009, which basically did not supersede anthropometric measurement, but it took into account anthropometric measurements along with staging of disease to complement it. And it has been shown to be superior to BMI in predicting all-cause mortality. And they are staged based on cardiometabolic outcomes and functional outcomes. So what is the goal and therapy? If you look at the BMI-centric model, then it is to reduce the BMI. But if you look at the complication-centric model, it is basically to decrease the obesity-related complication while achieving weight loss as a part of it. And thus, in this ideology, lifestyle modification, medication, endoscopic interventions, and surgical intervention will all fall in place. One such model you can see on the right hand of on your right hand of the screen, which is the Australian model, using the similar, and the another model which is currently practiced in the Asia group by our physician colleagues. And you can see diseases are staged here. The information collected is not solely an information about BMI. It includes medical history, it includes examination, it includes functional assessment, it includes investigation, and then you stage the disease and use BMI within that to propose treatment strategies which, over increasing BMI, increasing stage of disease, will become more and more intense. What does this then mean to us? What it means to us is that this algorithm will allow us to set goal strategies. So for patients between 30 to 40 BMI, the strategy is to get them to lose 10 to 15% weight loss, which will show immaculate improvement in their comorbid illness. And those above 40 BMI to basically lose more than 15% in order to decrease this. Any benefit, any weight loss is beneficial in this. And this then actually allows for proportioning of healthcare resources in public sector that we have, so that patients who are not in so urgency and are less complicated can be managed in primary healthcare. For example, those with 30 to 40 BMI without complications versus those who are 40 with or without complications who need immediate attention and higher degree of intervention may be referred to tertiary institutions. So this is a strategy that will help us diffuse this population. And why do we need to do this and follow this model? We know in Asia we have rising trends of obesity with overwhelming chronic disease burden, and surgery alone or any, for that purpose, lifestyle alone will not be able to manage these patients. So we need to strategize who needs treatment first and who could benefit from these treatments. We know as we look after populations who already have been inflicted by this, those who are younger and who are coming into this disease burden, we can look after them earlier, as earlier intervention will prevent them from not only having complications, but continuing to progress in the disease. The economic outburst and growth in Asia contributing to 70% of world economy, whereas is absolutely prevalent and is good for Asia, but it has brought with a disease of burden of obesity and weight loss. If I were to ask myself as a team, including physicians, surgeons, nurses, dietitians, physiotherapists, endoscopists, and surgeons, and then primary healthcare, do we have the bandwidth to manage the scale of epidemic of obesity that is going to land on our doors in the near future, and in some countries is already there? The answer is probably no. And so it is equally important now for us to settle down and think about how we will manage the epidemic of obesity along with its harbinger comorbidities in a strategized fashion. And I think the complication-based model is one of the best answers. So this is our solution, where with increasing BMI, you have increasing interventions, increasing stratification of where these patients should be managed. And as the risk of their comorbidities increases, and health risk increases, we treat them at different levels of care. With that, I would like to thank you very much for your kind and patient listening, and I will take questions.
Sim, thank you very much. You covered a lot of important ground there very quickly and eloquently, so thank you very much for covering that. I think, as you've rightly identified, this is particularly key in our corner of the world where, as you outlined beautifully, if we are waiting for those higher BMIs, in a lot of ways, we're already going to be too late, and we're going to be treating end-stage disease. With that in mind, across the APC, are the criteria themselves the key barrier here, or are we still having trouble reaching the patients that even met the more stringent criteria we saw before? Is there something else? Criteria are one part of the equation. What do you think is the key barrier? Do you think these criteria are going to be enough? What's the next step to get people treated?
So I think nowhere. Thanks, Alex. Thank you for that very kind introduction and So I think you see nowhere in Asia, not even I think in the very developed places like Australia, India, China, where the huge populations are we even operating about 1% of these patients who actually need our help. So even with the most stringent BMI criteria, we couldn't get to them. And it is not only the fact that are there not resources available? I think there is a whole lack of education. It's a whole lack of everybody coming together. The fact that we believe in each other's strategy. We see each other as collaborators and partners in the care pathway, and not, oh, I can do this, you cannot do this, and you do this, and I don't do this. So if we come collectively, so we have our pool of patients, the endocrinologists, then the respiratory medicine, then everybody has their own pool of patients. But where is the patient? Is the patient getting the right information? If we put our forces together and all these societies come together, issue a joint statement that you have to, if this patient can be helped, we can help it in this way, in this model, then I think we can collectively break the barriers, because then the information that goes out to the patient is uniform. They hear the same vibes from everybody. They get the same vibes from everybody, and not that, oh, you shouldn't go for surgery, or you shouldn't go for medical therapy, or you shouldn't go for acupuncture, or you couldn't do this. It's not the shouldn't. It should be what is the should. And we have to convince each other that we are on the right track. Thanks.
I think that's very well said. And as soon as you talked about this, it sounds to me very much like the success we have with a team-based approach to diseases like cancer, and we've seen spectacular results. And so I think you described that beautifully. In the interest of having some time for questions later, we're going to move on to our next speaker, and we'll join all together after that. I would remind all participants, anyone that has questions that they would like to direct to any of the speakers tonight, or to the panel in general, about the topics discussed, or anything else you think is a key issue coming towards us this year and in the years to come, please put them in the question and answer panel that you'll find at the bottom of your screen. We'll move on now. Our final speaker for tonight is Dr. Mark Magdi. He is a bariatric surgeon from Sydney in Australia. He has he's also practiced trained overseas in the USA, and he has a keen interest in holistic patient care. And we've asked him tonight to talk to us about, again, one of the key issues coming our way this year, next year, and the years to come, and that is the use of anti-obesity medications and the massive expansion in their role across the world and in the APC as well. So we'll hear from Mark now. Thank you.
Thank you for the opportunity to present this evening. I'm presenting on the impact of medications as alternatives and adjuncts to surgery and the expected uptake in the Asia-Pacific region. These are two billionaires that I think we'll all recognize. They've all been very vocal with their usage of GLP-1 agonists, and that's created a public awareness of the disease and the acceptance of obesity as a chronic health condition, as opposed to as solely from the result of poor food choices. The weight loss industry is obviously a very lucrative industry, and there are many pharmaceutical companies that are targeting this space. Interestingly, there's an article about how the stock market's been Ozempic, and major corporations, and in particular in the food industry, have had to change their practices because of the rapid uptake of Ozempic. For example, some of the food companies are actually producing smaller size servings due to the demand of Ozempic and the decreased eating habits. So two major players, we can look at them from a financial point of view. Eli Lilly on the left-hand side, they've had a major growth in their share price. It's risen by 451%. Likewise, Novo Nordisk has also seen a 364% increase in their share price. This is a direct reflection of the demand for the drugs and the uptake. Unfortunately, some companies haven't experienced such a large growth, and quite the opposite. They've decreased quite significantly. On the left-hand side, you can see Weight Watchers, and they've had a very significant decrease in their share price. And ResMed on the right-hand side, this is a company that produces sleep apnea machines. As a result of the weight loss from the different pharmacotherapy that's available, they've had a very significant decrease in the purchasing of CPAP machines, and as such, their share price has dramatically decreased. On the left-hand side, you're going to see the traditional target size for pharmacotherapy. And what we were previously seeing was it was a single agent for a single site. On the right-hand side, the complexity of the drugs has increased dramatically. They're targeting multiple sites with multiple agents. So GLP is now being mixed with GIP. It's also being mixed in the trifecta with the GIP, GLP, and glucagon. Taste buds and muscle are obviously also being a very significant target site in the newer agents that are coming out. On the right-hand side, you're seeing a list of different clinical studies that have been completed. Almost every month, at least 3 to 4 clinical studies were completed in the weight loss space. And as such, the area of research has exploded exponentially. On the left-hand side, I want to make specific mention of a monoclonal antibody that targets the actin-2 receptor. And what you're seeing at 48 weeks, it's a once-a-month infusion, and patients were experiencing roughly 30% decrease in their fat mass, but uniquely so to all other drugs, they were also experiencing an increase in their lean body mass. So the concerns regarding sarcopenic obesity and lean body mass preservation are also being targeted with newer pharmacological agents. The rapid uptake is because these drugs are inducing roughly 10 to 15% total body weight loss, and at that result, we're seeing improvement in diabetes, dyslipidemia, hypertension, fatty liver disease, and other obesity-related comorbidities. Whilst obesity surgery is superior to this in terms of results and total weight loss, the resolution of comorbidities can be seen with quite a modest weight loss that these drugs can induce. What are we seeing and experiencing right now? The impact of the drugs is that they're effective, there's no doubt about them. They're tolerable in terms of their side effect profile. 1 in 4 patients currently does not respond to the drug. At least in the Asia-Pacific region, we're experiencing major shortage supplies, leading to frustration for both patients and healthcare professionals. They're relatively high cost, and they're quite convenient in the sense that some can be administered as little as once per week. However, when you look at the consumer, in a survey performed in the US, 76% of patients in the US preferred medication as a first-line therapy. And that's not just unique to the consumer, but from a healthcare professional point of view, healthcare professionals were far more likely to recommend medical therapy as opposed to a bariatric intervention as a first-line therapy. So the translation of all these findings is that there's been a very high uptake of medical therapy as at least a first-line therapy. Positively so, though, there's been an increased recognition of obesity and acceptance of obesity as a chronic disease. And there has been a delay to surgical intervention because most people at least want to trial at least a short course therapy of medical therapy. The concept of surgery plus, this is akin to sleeve plus. So we talk a lot about the sleeve plus a SASI or sleeve plus a SATI or sleeve plus another intervention. So surgery plus medication or bariatric intervention plus medication is likely to be the gold standard. And we're already experiencing that. You can see from intragastric balloons alone, they can get 10 to 15%, but augmented with a GLP-1 agonist, we're seeing almost 20% total body weight loss. Similarly, in the endoscopic sleeve gastroplasties and even bariatric surgery, the traditional sleeve and bypass, typically we're seeing GLP-1 agonists being prescribed roughly 3 to 5 years post-procedure when there is an element of slight weight regain. Overall, though, statistically speaking, in 2023 alone, 16% of patients who underwent bariatric surgery were likely to be prescribed a GLP agonist within 2 years of their index operation. And overall, between 2021 and 2023, roughly the number of patients prescribed a GLP-1 agonist tripled. What are we expecting in the future? So there's a number of different schools of thoughts, and we'll cover those different schools of thoughts. One of them is that it's going to be a mandatory element of medical weight loss, where the patients undergo a period of time where they see their response to medical therapy. This is the complete opposite to another school of thought where the insurance companies will actually increase their coverage for bariatric surgery to combat the long-term costs associated with long-term medication use. What we're seeing in the US, at least, is that there's a direct consumer model whereby the pharmaceutical companies are directly targeting consumers. And this will obviously skew the direction of treatment in terms of pharmacotherapy. The concept of neoadjuvant and adjuvant treatment is also akin to, say, for example, oncology treatment, where it's multimodality treatment in terms of radiotherapy, chemotherapy, and surgery, and that model of care will likely be extrapolated to bariatric surgery. Interestingly, a large group of people think that there will be a change in the operative technique. So, for example, if you believe that reflux is a direct result from the tightness of a sleeve, the modification of the sleeve technique, for example, widening the sleeve to 42 French, preserving the antrum and minimally disrupting this cardioesophageal junction, accepting the fact that patients will be on a GLP-1 agonist or equivalent in the future, will mean that there can be a modification in our current surgical technique. The perspective from the medical device company is that this awareness of the drugs will create increased uptake of surgery and it will become more acceptable. And another school of thought is that there will be a resurgence or a comeback of previous bariatric techniques such as the gastric band, because they will now be used in conjunction with medical therapy to see, and the results may change. What's not understood is the side effect profile in its entirety, and they may change in the near future. And by definition, there's a high element of poor compliance in the bariatric industry, and as such, there might be frustration with long-term compliance from bariatric patients, which may skew them to surgery in the future. Ultimately, in summary, the take-home messages are there's likely to be a progression as opposed to a regression of the weight loss medications, given the amount of research and funding that's being placed in this space. There's going to be a greater acceptance and awareness of obesity as a chronic disease. Combination or multimodality treatment is likely going to be the gold standard of care, which will involve medication and the different treatment modalities that we currently have. And the current bariatric interventions that we currently have will continue to exist. And if not, there'll be a modification or an adaptation of the current procedures to also incorporate the medical therapy. Thank you.
Excellent. Thank you very much, Mark. Again, covered a lot of ground in a short time, and we appreciate you doing it. It's certainly an interesting, very interesting space. I do notice that you mentioned the share in Weight Watchers plummeting in the face of these agents, and then I noticed Weight Watchers Clinic is now an entity whereby Weight Watchers have embraced medications and now offering clinical medication management as I guess a way to reverse that trend in their stock price. So we'll see how that catches on. Before we go down, we finish the formal talks, I'd like to introduce our final panelists for this evening, Paolo Porciuncula from the Philippines. Welcome, Paolo. Paolo is an active bariatric surgeon. He is currently works at St. Luke's Medical Center in Quezon City, Philippines. He's a training officer for the Department of Surgery in that hospital, and he's the Assistant Vice President of Medical Services in Providence Hospital. He's also the Secretary for the Philippine Society for Metabolic and Bariatric Surgery. Thanks very much, Paolo, for joining us as well.
Thanks for having me.
I'd like to throw to you. I'm sure that the talks that you've heard so far have got you thinking. I'd like you to really put our panelists on the spot and make them work for their time.
Actually, these topics are really, I mean, the things that are happening in the past few years has really made some impact in bariatric surgery as a whole. But I'd like to toss some questions first to Dr. Asim. One of the things that really is groundbreaking is that having a multidisciplinary approach in the treatment of obesity. And for years, we're just embracing the simplified version of BMI as the rule of thumb. But if we're going to have this kind of multidisciplinary approach, won't it make things more complicated?
Thanks, Paolo, for that. No, it won't make it complicated. If you look at when I presented history 2005, Asia was already thinking ahead. It's just that mindset change needs to come in. We already had our BMI threshold lower. Why did we put it lower? We understood diabetes was a disease. But then we just telescoped in, went into a microscope, and just clinged on to diabetes. There were many more left behind. There were PCOS, there were obstructive sleep apnea, there was hypertension, there was hyperlipidemia. There were many of those. We didn't stage them. We've been there. It's just a mindset change that we need to adopt to understand that this is a collaborative effort and not an individual effort of a person. Once we change that mindset, then everything falls into play because we already have. So, as I said, 2005, we were there. We didn't take BMI to be the indication for surgery. We said, and that's why if you look at the revolution in Asia, which is sleeve plus procedures, which is coming, why is it? Because people are not trying to treat obesity. We have great operations. We've got urinary switches, we've got sleeves, we've got bypasses, we've got everything to treat obesity. But here is a continent trying to treat something beyond what the world even thought in 2005. Treating diabetes, right? A bugbear. So I think as we now know more about the outcomes of our bariatric procedures and then applying them to metabolic surgery, what we need to now start developing, apart from the multidisciplinary teams, is a collaborative journey for the patient to say that, look, we will start here. You will look after them. If you fail in this, you send them to us. We will fix them and we'll send them back to you. And as surgeons, we also need to playing a role in prevention of obesity. That look, guys, you know, we need to sit with our counterparts to plan community interventions. I mean, for how long will the communities be held ransom for what is a disease? Right? So it's just like a MDT for oncology. Everybody comes together and says, well, this is the best approach for this patient. But not every cancer then comes into MDT as well. Thanks. I hope I answered your question.
Oh, yeah, definitely. It's really good that this kind of thing has been in the picture already for the Asia Pacific region. Unfortunately, for many, I mean, in my experience in my country, many still embrace what the approach is for the Americas or the Europeans. So the gains that we have had here in the Asia Pacific region may have not been embraced so much. Do you think that it would help if this kind of collaboration, we will also involve the communities as well as legislation like politics, for example, because you've seen in the impact that just political figures have had in making obesity known as a metabolic disease, right?
About certainly, most certainly it will help. Now, and politics is something which even politicians don't understand, I'm sorry to say. Right? So, if you go and put it into politics and say, oh, policymakers, you could accept obesity as a disease. And that means not billions, but trillions of dollars now need to be pumped officially by governments to look after this population and the fallout from this population. Can you imagine the fallout where we are already, many of the countries are pumping less than they require of their GDPs into healthcare? Now you suddenly present somebody with even a problem with a huge magnitude. So that's very controversial and will meet resistance at every level, including bureaucracy, politicians, before it makes its way through. I mean, the American Association, the American Medical Association, has recognized obesity for the longest time as a disease. Has it come up anywhere in the national charter that this is actually a disease and we're going to treat it like cancer or like diabetes? The answer is no, because again, the economic implications, the financial implications are huge. Now, when we talk about collaborations between endocrinologists and other specialists, where we got ourselves wrong was just like what I see in today when I do administration, accountable discharge of my patient. When I discharge a patient, what do I want? I want this patient to go to primary healthcare and not come back to my facility. But I will not write him a physician letter, right? So if a physician does not know what's happening to the patient, they get upset. They said, oh, I sent my patient to you. You did whatever you did, and you didn't tell me what's happened to my patient, right? And this is exactly the stance that we took over as surgeons. Endocrinologist says, you take our patients, you don't send them back to us. We do not know what's going on with them. Then suddenly they turn up with hyperglycemia. And then you say you've done the best job. And then here we are to manage complications, right? So we need to develop confidence and trust between different specialties that, look, we will do our bit and you can manage the patient. That's what we do in oncology, right? We get rid of the cancer if it's surgically resectable and return the patient to the medical oncologist and say, well, look, you guys can carry following up. If there's anything surgical, please send back to me. And that's true. So I think we need to go back to those models of care. And I think then we'll find ourselves on softer grounds and more collaborative. Thank you.
I think, Ahmed, this speaks very well to what you mentioned in the theme of the conference this year, being integration and bringing groups together. I guess, what are the key players there? Because I think when we think about integrated health in bariatric surgery, we're often thinking about the dietitians and the psychologists, but Asim, and I think for your conference, we're talking about something different here. What does true integration look like from your point of view for this disease? That was for you, Ahmed.
Oh, sorry, Alex. I thought you were
muted.
directing it to Asim. Sorry, I thought you were directing it to Asim.
Nice try.
I think as Asim sort of indicated, I think we have to think broadly, and one of the things that I think Asim is hinting at is a little bit akin to, I guess, the way I've expressed it when I've been trying to advocate for public bariatric surgery, and that is. And I'll come to the point, but that is, if in our public hospitals we are not offering public bariatric surgery, then we're actually not offering standard of care for the management of sleep apnea or diabetes or infertility. Because whilst it's not the only treatment for those conditions, it is an important treatment. And a service that doesn't have that is lacking that standard of care of treatment. So really our collaborators are the whole medical profession. And then outside of that, we do need to develop collaboration with policymakers if we're going to tackle obesity as a whole. Asim's quite right. The size of obesity means that it scares politicians, bureaucrats, etc. The economic argument, if you just look at surgery, is actually a difficult one to make. We can all show cost-benefit studies, but any economist worth their salt is going to look at you and say, even if you operated on 3%, you currently operate on 1%, even if you operate on 3%, you're not going to make any meaningful economic impact on the disease of obesity. It's far bigger than that. So Asim's right. We need it's all of our colleagues, all of our health professionals, and we need to develop sensible strategic partnerships with policymakers if we're going to tackle obesity globally. And so it's multimodal care, it's multidisciplinary care, but it's actually sort of, if you like, trans-occupational care as well, because, you know, the way we govern medicine is also important here on such a, you know, in the disease with such a large scale. We have to stop fighting, and Asim was suggesting, you know, was hinting at that as well. Not just with our preventative health colleagues or our medical colleagues or so on, not just with those, but even with policymakers. I think very often we see them as adversaries. That actually isn't a strategy that's going to work very well. You need to look at what is important from their side and how do we meet in the middle? Where do we get to? Because otherwise our patients are going to continue to suffer. They're not going to be able to access treatment, regardless what model of treatment we use. They're just simply not going to access it if we don't provide the environment to do it.
Yeah, and touching on that, I think another area that you touch on there is this acceptance of poor outcomes for people with obesity. And is that something we need in a benchmark? Because in the cancer world, we don't accept poor outcomes for people with cancers. If you know, we benchmark ourselves against the world, we all compete with remission rates and survival rates and all these sorts of things. And you know, we look down upon and frown upon centres or areas of the world where outcomes are poor for people with that disease. Is that what we need here? Is that what we're missing?
I think there is a certain nihilism about obesity from all sectors, you know, policymakers and hospitals and clinicians and so on. But and so that level of nihilism means, yes, we do maybe accept that, you know, we just throw our hands up and say, well, it can't be treated or it's their fault or whatever else. I think that tide is changing. As Mark very eloquently demonstrated, one of the great advantages of the medical therapy and its success, whatever that is, whether that's limited to a year or whatever it is, doesn't really matter. I think its biggest impact is, in fact, the shift that it creates in the minds of everyone, of primary health caregivers, of specialist caregivers, of policymakers, of general community. It shifts obesity to a disease model way of thinking. Once treatment is accepted, as in medical treatment like this is acceptable for this condition, surgery becomes more easily acceptable. The concept that we need to treat this to a standard becomes more easily acceptable. I think that's actually the greatest impact that medical therapy is having, and Mark, you know, demonstrated that very nicely. And I agree with Mark that I think actually ultimately improved medical therapy will actually lead to increased use of surgical intervention because it'll just be more acceptable to treat it.
Yeah. What do you think, Mark? You mentioned a group of potential outcomes here. Is this going to look like reflux, where only the people who get no effect from the drugs are going to come for surgery? Is this going to look like more like cancer care, where just about everyone gets a combined approach? Or is this going to look like something different again? What do you see coming out of this through your crystal ball?
Yeah, look, I honestly think it's going to be multimodality treatment. The reality is that I think we've all seen in our practices, people have been on Ozempic, it works to a certain degree, and then they're coming and it's triggered their interest. These are patients that would have never thought about bariatric surgery, but it definitely has stimulated their interest, and then they take the next step and it's more acceptable. And there will be a group of people where they have medical therapy, they have a great result, and they won't proceed to surgery. And I don't think there's anything wrong with that whatsoever. If they're getting their improved medical outcome, they're having a great result, they're happy to pay for it, then that's also a win. I think overall, our objective is to improve people's health, whatever modality that may be, whether it's surgical, whether it's medical, whether it's a combination of both. But yeah, like everyone has alluded to, our problem is not we don't have enough candidates. We have more than enough candidates. Our problem is that the uptake, like there's people not willing to embark on that. That's our biggest problem. And, you know, when the world's richest man says that he has an obesity problem, then the whole world changes. And so all of a sudden, there's this notion that when you give someone medication, they've got a disease. And so, yes, now being overweight is a disease. And so treating it with a surgical intervention is no longer taboo. There's nothing wrong with it. So I think overall, it's a win-win for everyone. And I do think that we're going to increase our surgery significantly.
Yeah, and we've got one talk, probably one more question we've got time for from the participants. What is considered therapy for obesity? Is it a particular duration, time frame, BMI, weight change? And I'm going to broaden that widely. What is failure for us now? In Sim, I'm going to ask you, in the complication-centric model, what does failure look like in that model? Is it a failure to reach a certain BMI? Is it a failure to achieve weight loss? What does that look like for you? And I'm going to ask each of the panelists to tell me what failure for treatment of obesity looks like.
I wouldn't say there is any failure, right? I think because it's a chronic relapsing disease, you just got to keep coming back with options. Now, you shouldn't tell the patient you have failed. You don't tell an oncology patient, the cancer patient, you know, I gave you this drug, you failed. You say, well, this didn't work. Let's try something else. Is 5 years survival in oncology good? People have now talked about 10 years survival. So I think success and failures are things that me and you define. Maybe if you just want to press on it, less than 5% weight loss may not be good for me, because it may not have brought a benefit I wanted to see in a patient, but still the patient still benefited. I wouldn't say it's success or failure, but you could do better, and you've done better. Thanks.
Ahmed, your final word on what?
Well, broadly similar to Asim. One of the things we can't escape is patient expectations. So that's always a tricky thing to balance. And we can talk about health, and we can talk about all of those things. And we know that 10 to 15% weight loss is plenty to achieve most of those things. But we're still needing to deal with people and people's expectations. And we have to weigh that in. What that really means is guiding their expectations. We can't accept unrealistic expectations, but that is part of our therapy, is to manage those expectations. So I would urge everybody that's involved in this area to understand what the normal outcomes are, what outcomes are required for health benefit, and to always guide patients towards those sort of expectations.
And I think from everyone, the key thing I would sum that up is this just sounds like good medicine. I don't think this sounds like anything particular to bariatric surgery or obesity or anything else, but just good medicine. And I think that's what I've heard today, is a group of caring clinicians who are just keen on practicing good medicine, whatever form that takes. So I'd like to thank you all for joining me tonight and putting on this webinar. And I sincerely hope it helps the attendees and those that watch it in the future. Thank you very much.
Thank you.
Thank you.